Hi. Firstly, my apologies that you're going to have to hear me drone again for another half hour or so. My apologies as well because indeed last night at the bar they handed me a cocktail and a beer, and after I consumed them they said, by the way, you have to give Phil's talk. So I had to put together a talk last night in a state that is not sober. So anyway, without further ado, how to treat upper GI disorders in 2019. So just to recap, the Chicago classification, we look at pathology in the esophagegastric junction, and then we look at the esophageal body. So we tend to want to treat esophagegastric junction pathology first, and only when we have excluded pathology within the esophagegastric junction do we then proceed with the esophageal body. We treat major motor disorders. In this context, we treat the disease. While on the other hand, in minor motor disorders, we treat the symptoms if we're going to treat at all. This is because minor motor disorders, over time, tend to improve or tend not to be significant. So if patients who have minor motor disorders, this is a good prognostic indicator, and patients should not be worried that they have a disorder per se. So achalasia is the first pathology that we should be concentrating on. This is the most common disorder that we are able to treat in the gastroesophageal junction. And when I say achalasia, I also extrapolate therapy towards other hypercontractile disorders of the esophageal body, which include diffuse esophageal spasm, as well as jackhammer esophagus. And also there's an overlap with type 3 achalasia. So in all of these, the treatments are not dissimilar, although if you have pathology in the gastroesophageal junction, you treat those first. So first, achalasia. We know that achalasia is subtyped into type 1, 2, and 3. Type 1 is the classical achalasia, big baggy esophagus, narrow lower esophageal sphincter, and on manometry it looks like this, big blue C in the middle of the esophagus, non-relaxing lower esophageal sphincter. While type 2 is a pan-esophageal pressurization with a non-relaxing lower esophageal sphincter, and this is because in type 2 there is the esophagus has not yet decompensated, so it is normal diameter. Type 3 is a different animal. Type 3 is a lumen obliterating disorder, whereby you have a non-relaxing lower esophageal sphincter and spasm. Also, esophagogastric junction outflow obstruction, which used to be called variant achalasia, is another form of obstruction. So that needs to be considered as well, because ultimately it's a pathology in the esophagogastric junction associated with a non-relaxing sphincter. Now, hypertensive motility, which is known as jackhammer esophagus, is a hypercontractile disorder of the esophageal body. And this is associated with pain and impaired bolus transit. So this too can be treated in a not dissimilar way, and we'll talk about that in a moment. It doesn't have to appear like this. It can also have just very high contractile motility. And both of them have a high distal contractile integral. Now, when you put these together, if you have a non-relaxing lower esophageal sphincter and spasm, this is type 3 achalasia. Remember, spasm is defined as a premature contraction, a distal latency that's short. So if the motility occurs too quickly, that is a premature contraction, that defines spasm. When combined with a non-relaxing lower esophageal sphincter, that equals type 3 achalasia, while this is diffuse esophageal spasm because there is a premature contraction but normal lower esophageal sphincter function. Remember, opiates can cause the same thing. So when we're treating any of these disorders, the first thing we need to ask before we perform invasive therapy is this patient on opiates? If so, can the patient come off opiates? Even over-the-counter codeine, cocodamol, can contribute to this. So how do we treat these patients as a whole? These are the treatments for achalasia, and many of them can be also used for hypercontractile disorders of the esophagus. So In the first instance, we want to avoid the end stage. We want to avoid the sigmoid esophagus of decompensated achalasia or any form of obstruction, whereby the esophagus becomes big, baggy, and tortuous, in which case there's not much else we can do but remove the esophagus. So we need to try and treat these patients as early as possible before we get to this stage and have to refer to Stephen Atwood. So, medical therapy. In achalasia, it's pointless. We should not be using medical therapy in this context. This includes calcium channel blockers, nitrates, even Viagra. But in hypercontractile disorders, such as jackhammer esophagus and a diffuse esophagospasm, there may be a role, because in some of these cases, patients do respond. We're not dealing with an obstruction, we're dealing with a motility disorder, in which case they might be able to respond, while in achalasia there's a functional obstruction which will not respond to medical therapy. What about Botox? Well, Botox is easy, safe, can be done during the day, can be as a day case, and it works, but it works for a short period of time. And over time, the symptoms recur. Even within 3, 6, 12 months, the symptoms recur or it wears off, just like it does in the face. That's why patients, for those who have Botox in the face, not saying any of you need it, but they have to have it repeated every 3, 6, 12 months. Okay? The issue here is that in achalasia, we should be avoiding using Botox if these patients have potential for other more definitive therapies, because other more definitive therapies are more likely to reduce progression and more likely to be effective over the long term. While on the other hand, in cases such as hypercontractility and diffuse esophagospasm, if they are not responding to medicines or not responding well enough to medicines, then they can, then Botox can be a good therapeutic option. But in achalasia, it can actually impact on other forms of therapy. So if you're going to do a per-oral endoscopic myotomy in somebody who's had 3 or 4 Botox injections, the likelihood of fibrosis is much higher and becomes more difficult. So we should only be using it in achalasia in patients who will not be having any other form of therapy or have too many comorbidities. Pneumatic dilatation, that's been around for many years. It is basically a balloon that is large and non-compliant and can disrupt the gastroesophageal junction. It is quote-unquote barbaric, but it works. It works very well. The balloon is inserted across and traverses the gastroesophageal junction and stretched. You efface the gastroesophageal junction, and so and it has to be at least at 30 millimeters, because anything less is not enough to disrupt the junction. So 18 millimeter, 20 millimeter balloon, standard balloon will not work. You need something that will actually disrupt the muscle. It works, it's effective, but patients will most likely have to come back for another treatment. But so what? This is a day case. They come in, have treatment, and they go home. And if this is effective and efficient and does not disrupt anatomy per se, apart from the gastroesophageal junction, and they're asymptomatic and it stops progression, what's wrong with that? That doesn't imply that they have failed if they needed another stretch. Indeed, graded dilatations is now the way forward, and I'll talk to you about the studies with regards to that in a moment. What about things that Stephen Atwood would do, such as myotomy? This has been around for many years. It's very effective. We know it works. We know that it is, until recently, the gold standard. Most folk should have had a myotomy if at all possible. At least the data showed that up until recently. It is, on the other hand, there is a small mortality risk because of it's ultimately a general anesthesia procedure. There are several days in hospital, and there can be pain. Effectiveness reduces if you've had other forms of therapy in advance. All patients nowadays tend to have anti-reflux procedure because in the absence of anti-reflux procedure, 60% plus patients will have reflux, and quite severe reflux, because there's a free flow of movement of gastric contents. And in so doing, patients are supposed to have reduced reflux with anti-reflux surgery. It's a partial wrap as opposed to a full Nissen. Now, what about comparing these therapies? How about dilatation versus surgical myotomy? Well, surgical myotomy trumps dilatation hands down when you're just doing one stretch. But if you do 2 stretches, this is graded dilatation, one stretch followed by another bigger balloon 2 to 3 weeks later, then the results are the same. This was an early study from Vela et al. In 2006, which alluded to this. Then there were more advanced, more recent studies published in 2011, and then another one more recent. This is 2-year data. This is 5-year data from the same group, from Leuven, multi-center, multinational, comparing graded dilatation with surgical myotomy. The results are exactly the same at 2 years and at 5 years, with a proviso that you allow for repeated dilatations no more than once per year in a graded fashion, 30, 35, plus minus 40 millimeters. The reason is that the bigger the balloon, the better the outcome, but the higher the risk of perforation. And so we reduce the risk of perforation down to 2% per procedure by performing the dilatations in sequence. And in so doing, the outcomes are the same. What about POEM? We've all heard about POEM. It's a new sexy thing. Well, it's not. It's been around for about 8 years now. It's basically doing the same thing that the surgeons do with myotomy, but instead of cutting the muscle from the outside, we cut it from the inside. Create a small incision about 13 centimeters above the lower esophageal sphincter. Create a tunnel that goes all the way down. This is the incision. Create a tunnel that goes all the way down beyond the gastroesophageal junction. You have the skin, the mucosa on one side, the muscle on the other, and you can see the muscle there. And we start to plicate the muscle, cut it all the way down, 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 beyond the GOJ. This is the muscle all cut. This is the mucosa here, which you were trying to avoid. And then we close the hole with clips. And voila. Okay, so there is no anti-reflux procedure. It's done in endoscopy under general anesthetic. Patients stay at home stay in the hospital for at least 1 day, and they go home the next day, if all goes well. The outcomes, the early outcomes, are fantastic, but of course they would be, otherwise they wouldn't be publishing them. In fact, the adverse events are also very good, depending on what you define as an adverse event. So adverse events of perforation is most common, but these can be treated with a clip. You close the hole with a clip and you get on with things. There is this thing called pneumoperitoneum, pneumomediastinum. Well, you use CO2 to inflate the tunnel. This can seep into the structures. If it seeps into the neck or into the abdomen, this is eventually exhaled. So it's not really considered a true adverse event. This is considered an expected complication. So if you exclude that, then the adverse events likelihood is very small. Comparing myotomy with POEM with surgical myotomy, well, there are no randomized trials, and so that is the only criticism here, that we are now describing the outcomes based on cohort studies, not on randomized controlled trials. We are involved in a randomized trial, which is ongoing. But comparative trials, comparing POEM with myotomy, show that their outcomes between the two are exactly the same. And pooled comparative trials show that there is no difference in total adverse events, perforation rate, operative time, and length of stay in the hospital. Now, there is this thing about, well, but POEM can lead to reflux. Goodness, the reflux is awful. Why would you want to do this to a patient? Well, if you look closely, all the results that are being presented with regards to how severe the reflux is, depends on how you define reflux. Are you looking at endoscopy? Are you looking at pH monitoring? Are you looking at the need for PPIs? Or are you looking at symptoms? So each of these in different papers are defined as reflux. So we have to be careful how we define reflux and who's writing the paper. Now, if you look closely at the endoscopy, almost all of them are grade A esophagitis. Remember this morning we talked about grade A esophagitis, and that grade A and normal have a big overlap, and we shouldn't define grade A esophagitis as reflux. So in this context, many of them have grade A esophagitis. Also, when you compare pH monitoring, it's not uncommon that the pH studies are very similar to that of post-anti-reflux surgery, post-myotomy and reflux surgery. So we'll talk about this in a little bit more in a moment. The only other caveat here is type 3 achalasia. It appears that in type 3 achalasia, POEM seems to have a better outcome. The reason is because type 3 achalasia, as I was describing earlier, is associated with spasm, and that spasm can reach the proximal esophagus. If you're doing a surgical myotomy, there's a diaphragm, and there's only so far the myotomy can go surgically. With POEM, you can go as far up as the transition zone. My longest POEM was 21 centimeters, no, 24 centimeters. And in a patient who had, he had spasm that reached the entire, the transition zone, and he was 6'3" or something. So it was a huge myotomy. But the patient's completely asymptomatic and has gained about 20 kilograms in weight. What about reflux disease? How do you treat reflux disease? Well, again, like we were discussing this morning, reflux, is it a disease? Many of us have reflux symptoms. It's not uncommon. It's common in the community. Is it really a disease worthy of investigating? If we're going to treat it, what are we really going to be doing? Are we really treating a disease or treating something that we all experience? So if the patient does have true reflux disease and you want to consider therapy, lifestyle modifications have been proposed. To be honest, in the literature, there are only so many lifestyle modifications that's actually proven. There are a lot of books that define, stopping acid from being consumed and acid-forming foods and reduce the acidic content of your meal. All that is bollocks. There is no evidence that any of this works. There is evidence that reducing fat and reducing calorie content of your food does reduce reflux, because it reduces reflux events and sensitivity to reflux. There is evidence that raising the head of the bed helps. There's evidence that chewing gum helps. And there's evidence that weight loss helps. But stopping caffeine and reducing alcohol and all this business, none of that is of any proven benefit. Sorry, this is this slide. That's what this describes. What about therapy? We talked about this morning how acid-reducing medications, such as proton pump inhibitors, work best in erosive esophagitis and Barrett's esophagus, and work least in endoscopy-negative reflux disease and functional heartburn. But the patients we see tend to be those guys who are more difficult to treat. So when patients are on acid-reducing medications and they're not responding, what's the first thing we should do? Discuss compliance. It's not uncommon that patients who are not responding, in fact, are not taking the drugs properly. They take it every other day. They take it only when their symptoms come on. They take it after food. They need to understand that these drugs are not antacids. They're acid reducing. They need to be absorbed in the system and then stop acid from forming. So if you have reflux now, this drug is not going to affect your reflux now. It's going to affect your reflux later. So they shouldn't be taking it to treat the reflux now. Of course it's not going to work. You should take it in advance. It's a prophylactic. So compliance, that's the first thing to discuss. Second thing is switching the PPIs. It's not uncommon that if patients who don't respond to omeprazole perhaps will respond to esomeprazole, perhaps to lansoprazole, the formulation might change. And doubling the dose as well can make a difference in some patients, especially if they have a sensitive esophagus. Taking twice daily or taking double dose in one go. Different patients might have different responses. So that's worth always considering. H2RAs, ranitidine. This can be of benefit as an add-on therapy, especially at night, in addition to daytime acid proton pump inhibitors. Evidence is very poor, but clinical experience is evident that these patients sometimes do respond, especially if they have nocturnal events. Alginates, such as Gaviscon. Benkis are here, so I'm sure they'll be happy. I'll describe Gaviscon works. It works very well. And the reason it works is not because it's just an antacid. It doesn't just neutralize. What is useful here is the alginate forms this sort of raft over the food. And it's a foamy raft that is a reflux suppressant. And if you do reflux, you're refluxing the raft rather than the food. So in other words, this should be taken after food, not before food. So if you're going to take medicines, the Gaviscon should be taken after meals, while the omeprazole should be taken half an hour to 30 to 60 minutes before food. And that combination, plus minus ranitidine before bedtime. So that combination will render you non-acid and non-refluxing if you do indeed have symptoms. Now, if on top of this, patients say, I still have a burning sensation, it is very unlikely that these patients' burning sensation is acid. You could do the test to prove whether or not these patients indeed have reflux. But in this context, it might be useful to do the test on PPI to prove that they don't have reflux, assuming that you have proven that they had reflux in the first place. Now, Indermani will have an argument about whether we should do it on or off PPIs, but that's another discussion. Baclofen. Baclofen works. It reduces transient lower esophageal sphincter relaxations, increases lower esophageal sphincter pressure, and it is also a prokinetic. However, patients don't like it because they tend to become drowsy and have side effects. But it works, especially in patients who are not responding to diaphragmatic breathing of rumination, for example, or supragastric belching. And these drugs are the most widely studied with randomized trials. Trazodone, tricyclic antidepressants, SSRIs, SNRIs. These drugs work if we're treating sensitivity. As long as the patient believes that they don't have a organic disorder and that they have a sensitivity to normal reflux events. So it's always important to establish the patient's understanding of their disease. And if they feel and if they are insistent that they have a disease that requires treatment in some form of invasive way, none of these drugs are going to work. Of course, there's surgery. Surgery works. It works very well. But the problem is that you're not curing reflux. You're transferring one set of symptoms to another. And Steve might be discussing this further in more detail, so I won't dwell on it. But, and again, I won't dwell on these studies because I'm sure Steve will mention them, but Lotus trial showing that omeprazole versus surgery have equivalent outcome over 5 years. Same with the Sopran study. One single dose omeprazole versus surgery, surgery beats. But if you allow for increasing escalating therapy, then they're about the same. But anti-reflux surgery is associated also potentially with other complications and disorders, and I'll leave this for Steve to describe. So I don't know if you can see this. Here's a potential algorithm of how to treat reflux disease. So endoscopy, if there is esophagitis, PPI or surgery. If there's Barrett's, PPI or surgery. And of course, you have to do surveillance for Barrett's now. If there's a stricture, you need to dilate. If if the endoscopy is normal, then we can proceed with impedance pH monitoring. If there's reflux disease, then you can optimize PPI or give another form of medication or surgery. If it's functional heartburn, then you avoid surgery. You potentially avoid PPIs if you can convince the patient to come off of them. And if there's hypersensitive esophagus, that means negative acid exposure time but positive symptom association. You treat these patients potentially with medications such as with functional heartburn, with tricyclics, SSRIs, etc. There are new kids on the block. There's endoscopic fundoplication, recreating your angle of His in order to reduce reflux. This is the results of these are positive and negative. It's not clear whether they work. They do sometimes reduce symptoms but don't improve pH studies, or the pH studies are better but are not in the normal range. It's not clear how they work over a long period of time. So they're primarily done in the private sector or the research setting at the moment. Same with Stretta. Stretta has been around for many years. It's a radiofrequency device that sends energy into gastroesophageal junction. We don't know how it works. It might alter anatomy at the gastroesophageal junction, or it might neuromodulate by reducing sensitivity to reflux events. We don't know. Some patients improve, some patients don't. pH studies show that not all of these patients tend to have a resolution of their pH, of their acid exposure time, but it can improve. Again, it's not available widely. It's primarily private sector. We're trying to get it at UCH. I think it's available at St. George's. Somebody here is from St. George. So in conclusion, 2 slides of conclusion. Reflux-wise, we need to understand what are we treating, why are we treating this, are we treating a disease or are we treating a symptom? How is symptom association related to this? If you've got a patient who's got a high esophageal acid exposure but negative symptom association, what are we treating? Are we treating the number or are we treating the patient? Is there a hiatus hernia? How big is this? Small hiatus hernias are of no consequence, but massive ones might be. Does the patient want anti-reflux surgery? If they do, they need to understand that you're not curing reflux. You are changing your symptoms from one set to another. And Steve will, I'm sure, discuss those. And is invasive therapy appropriate for this patient? Because not all patients you should be touching, even if they are convincing refluxers. In terms of the hypercontractile disorders and achalasia, we should try and look at the patient as a whole. Is this patient worthy of invasive therapy, or is this patient got too many comorbidities, elderly and frail? If the latter, then we should try and avoid invasive therapies and try and perhaps do things like Botox. Otherwise, try and do something that is potentially going to last for prolonged periods, such as sequential graded dilatation, if you're going to do dilatations, or surgery. And if you have access to POEM, perhaps that's appropriate. But POEM is not the gold standard until randomized trials come out. It appears to be at least as good as the others as it stands. I think that's it. Yeah, thank you.